So today's presentation is called the predictive value of routine blood tests. I'll give I guess I was already introduced quite a bit about myself. I guess the co-founder of the Vogel Foundation, as well as Voloridge Investment Management and Voloridge Health. But more important than the titles, when people ask me, what do I do? I say, I'm a career data scientist. And that's the common thread. Always following the data. It's what we've done in climate research. It's what we've done in investments, and now what we're doing in health. So before I get too much into the biomarkers, I want to give a little bit of background about my motivation to get into the space. For the past 15 years, I could not get my LDL cholesterol down. I started this investment business in my late 30s. I was working all the time. I was eating terribly. I wasn't exercising regularly. And then I turned 40, and that's when I realized, okay, I probably should do something about my health. The risks are going to start adding up. And what caught my attention was being out of range on my LDL cholesterol. And so what I did the first thing was join a master's swim program. Started swimming 3 times a week. The cholesterol still wouldn't go down. And then I started exercising 5 times a week, and it still didn't go down. So then I thought, okay, maybe I should start getting rid of the sugary drinks and the Big Macs at midnight sometimes when I'm in the middle of working, and fix my diet. And I got a lot healthier. I was getting thinner and fitter and felt better, but that darn cholesterol still wouldn't go down. So that sort of made me scratch my head and think, okay, we're kind of missing something. And I asked the question, what if healthcare actually used this data? So we got access to a data set, the UK biobank, 500,000 participants, 40 to 70 years old, followed for up to 15 years. And what we found was a lot. It was astounding. First of all, there are many better biomarkers that are predictors than LDL cholesterol. Secondly, if healthcare actually used its data, we figured out that if people actually use this, you could use that to personalize decisions better, and patients could actually have transparency as to why they need to do certain things to be proactive. So there are about 5 or 6 poll questions in this, so I'm going to give people a moment to scan the QR codes. And while you're scanning that, I'll just talk a little bit about the UK biobank. It's not just, I'll be presenting here mostly on biomarkers, but they had everything from genetics, information, to length of telomeres, to metabolites, amino acid levels, all kinds of information we could use. And with that 15-year follow-up, we could figure out what was actually tied to, what biomarkers were actually tied to future disease. So the first poll question, many of you probably know that the recommended reference range for LDL cholesterol is to be less than 100. So based on the UK biobank data set, of people between 55 to 70 years old and not on cholesterol-lowering medication, what percentage have LDL levels that are out of range? So it seemed like most people had over 75%. So this group seems to be aware that it's more than half the people. If you pick 90%, you would be closest. It's actually 95% of people in that age range. 94% for men, 96% of women. That kind of explains why. Have you ever heard someone come out of the blood test? Well, everything was pretty much in range except my cholesterol was high. Why does everybody say the same thing? So we decided to look at this big data set and say, okay, how predictive is LDL, bad cholesterol, on the cardiac event? And on the x-axis is the range of LDL values, and you see just a tiny smidge of people not on cholesterol meds are on the left. Again, we took out all people on cholesterol meds, not to influence the data. And a risk ratio of cardiac events on the y-axis, or a risk multiplier. So 1.0 being the lowest, and you can see the people with the highest 5% of LDL cholesterol, people over 180. And you can see those people had about a 40% increased risk of a major cardiac event. So again, this doesn't disagree with the literature. It is a predictor of cardiac events. All right. This one, we saw the graph for cardiac events. This one is on all-cause mortality risk. For 60 to 70-year-olds that are not on cholesterol meds, what range of LDL has the lowest association with 15-year all-cause mortality? We've got 4 choices here. Okay, so some in each category. The answer is actually 140 to 200. It's the lowest all-cause mortality. And I'm not a doctor. I'm not making any recommendations here. I've just looked at 500,000 people and their actual outcomes. This is what the data actually says. So how low is too low? Again, we looked at the people with no prior conditions in this case, and we said, okay, if you're actually in the range, you're in that lucky 5%, you have a 20% reduction compared to the average of a cardiac event. But why do we only look at cardiac events? Is that the only thing that can happen to us? This is the association of people not on cholesterol meds, no prior conditions, like no prior cancers, no prior heart attacks, for metabolic disease, respiratory disease, liver disease, kidney disease, dementia, and mortality. Again, none of this disagrees with the research. But why is the research only done on one marker, LDL, and one outcome, cardiac event? I would think death is a pretty important outcome. So now it's been published in the research before, and people who are so set on LDL being bad say, well, maybe people have low cholesterol because of reverse causality. Maybe there are people already dying from something, and that's caused them to have low LDL. So we drew out the curve out 10 years. We said the yellow line are the people with cholesterol, LDL cholesterol between 140 and 200. And we compared that to the green line, which are the people in the recommended reference range. And you can see that that increase in mortality is not just happening in the first year or two. That those people with the low cholesterol, the low bad cholesterol, have higher mortality, and we've drawn this out to 15 years, and it just keeps going. It does not seem to be the healthiest group. So what we did after seeing that, we said, let's create a resource that can actually help people look at where they stand. Let's not just assume that the reference range is correct. Let's not give a recommendation. Let's just give people what the data says. So with our resource, you can actually, and again, you have a copy in your bag, but there's actually an online version that is more comprehensive. You can compare the risk of a given disease. Again, the risk multiplier of 1 means you have the lowest incident or lowest prevalence of that disease. And you can see people over 175 have a 40% increased risk of cardiac event. But how about if you're in the middle? If you're in that 90% of people in the middle, you want to be able to see what that risk increase is. And as it turned out, all these years where my cholesterol was between 140 and 150, and I was way above the reference range, I only had about a 10% increase in risk of a cardiac event. And that's, again, not conflicting with the research, because, again, a paper was published a long time ago showing very high cholesterol connected with heart disease. So it was assumed and taken into practice that the lower the better. And then you can compare it to other diseases. probability of type 2 diabetes with different cholesterol ranges, probability of COPD, liver disease, kidney disease, dementia, and mortality risk. And we've also compiled top 10 predictors, top 10 biomarker predictors for every disease, and LDL only makes the top 10 for one disease, and that's actually for dementia. And it's not being too high, it's actually being too low. It actually LDL ranks, I think, number 22 predictor for heart disease. So maybe we should look at some other things on the test. We also do this out separately for men and women. For many markers, it was very similar. But for several markers, like HDL cholesterol, the ranges are much different for men and women. So it's important to look at them separately. So we thought this was the best way to represent the data, the relationship between any given biomarker and disease risk, multiple different diseases. All right, next question. Okay, this one will be hard to do by hands because this was, you could pick multiple. So maybe I won't ask this question, but the idea is to sort of see what biomarkers are important in your practice when you're assessing cardiovascular health. Okay, I'm actually seeing the results. They're not coming up on the screen, but I see the results. And about 80% of people pick triglycerides. Actually, results are still coming in. So far, we have triglycerides in the lead, and then a 5-way tie for second place between actually second place, we've got Lp(a) and HbA1c. And then falling in third, we've got HDL and BMI. And in last place are cystatin C and white blood cell count. All right, I'm going to freeze the poll here. Whoops. All right. So if you listen to the data and you rank everything, the one with the least votes, cystatin C, #1 predictor of heart disease. Very close second, HbA1c. I've been told that many cardiologists will only measure your lipids and not your A1C. So this information is very important if you're actually assessing cardiac risk. And smoking history, HDL, good cholesterol, very solid predictor. One of the ones I thought was very interesting, actually got tied for the fewest number of votes, white blood cell count. It's been on our list for decades. It's a cheap test. It's in our CBC. And it's #5 predictor of cardiac event. So why do we pay so much attention to LDL, which is number 22 on the list, and not white blood cell count, which is inexpensive and been in our annual physical for years and years and years? Well, the reason, first, let's check the data out and make sure it's accurate. That number, that strength indicator I had is actually a nonlinear correlation. So again, there's no bias. Again, I'm taking data science approach. There's no medical opinion that went into it. It was purely what was higher correlated to the disease. So you compare LDL to white blood cell count again, and you look at the difference between people at 100 and people at 200 for cardiac event, and it's a 50% increase in risk. But we look at it because everybody is in red. Everybody's drawn out of the reference range. White blood cell count, on the other hand, the reference range is from 3.8 to 10.8. So everybody's in the green by definition, even though it's a much, much better predictor. It has twice the predictive power of LDL. 100% increase in risk from someone with a 4-ish number versus someone with a 10-ish number. And yet they're all still in the reference range. So now that we have all these great predictors, how do you make sense of it in your practice? It used to be so simple. We look at one predictor, we look at LDL, and that's your cardiac risk. Now we have a dozen good predictors. So what we did is we rolled it up into a predictive model and created a tool. So you only had to look at one risk that was a roll up of all your values. And you can see where you rank compared to other people in your age and gender. And then very important when you have a model, a lot of models out there are black boxes. So they tell you, okay, your risk is high, your risk is low. So it's very important to show the attribution. And so if you have a bad score on something, or if you're scoring suboptimal, we can break that down and show the components, and you can actually look it up in the biomarker reference guide and see, okay, my A1C is a little high, I'm getting risk from that. My BMI is a little high, I'm getting risk from that. So it's all broken down. Everything is transparent. So let's go back to my personal health journey, where I went for years and years and years trying to get my LDL cholesterol down. And it was only fairly recently, the last year or two, we had these models, and I could go and throw in all my past data. And I felt healthier. I was thinner. I was eating better, exercising, fitter. And sure enough, the model shows that my risk of cardiac event went down by a factor of 4. But I was getting no feedback along the way, and that would have been nice to know. If you're wondering, that little blip in 2017, my twins hit their terrible 2s, but as you see, I got back on track right after that. All right, this one is no like right or wrong answer. This is more curiosity to see what's more important in your practice. Do you like to know the absolute risk of someone getting a particular disease? Would you rather know relative risk, like how is that person doing compared to people their age? And then sort of the newer thing we're starting to see is an organ age. Like I'm 52 years old, but I have the risk of a 44-year-old, so my organ age is 44. That would be, and you've probably all seen this representation in various tools. All right. Well, this is one where I didn't know what the result would be. We have a kind of a two-way tie between absolute risk and organ age, and relative risk has only 15% of the vote, but it's definitely important. I mean, it's different from the view of a practitioner versus a patient. I personally, I know age is a factor, so the best I can do is relative age. So I try to look at that for my own personal benefit, but I can see from a clinical standpoint, it's important to know what is the actual hard risk you're treating for. And these are just ways you can present it. Again, this is just a hypothetical. These are made up numbers where a person can have a certain absolute risk of a disease, but in some cases they're doing better than other people in their peer group, and in other places they're doing worse. It just gives you an idea of where you need to improve. This was also, these models allow you to project. This is actually data from a 55-year-old who anonymously let me use the data for this. And their risk at 55 was much higher than the norm, fairly unhealthy smoker. And their risk maybe right now at 55 isn't that high, but you can tell if you project that risk and those biomarkers continue up to age 70, you can see that risk becoming quite substantial. And with these models, you can actually show you can change that trajectory. And this was we actually modified this person's biomarkers so they improved their BMI and their blood sugar and stopped smoking. And it shows how you can actually change the trajectory of someone's health. And I think that can be very encouraging, that people can know that they have the ability to change. And again, on the left column is their actual biomarkers, and certainly we put in hypotheticals for the numbers on the right. We assumed that they would have to lose over those 15 years, lose weight, go from BMI of 30 down to 23, they had to stop smoking immediately, so they will have quit for 15 years in 15 years. And that in turn increases, it helps the kidney function. That cystatin C is always popping up as a top predictor. Last poll, again, this was more, again, personal interest. And I want to let you pick one because I know, I know you all wanted to pick all, but I want to know what is the most important to your patients in terms of knowing what risk to be concerned about. We got cardiac, we got risk of type 2 diabetes is metabolic, respiratory, risk of COPD, liver disease, kidney disease, and Alzheimer's or some form of dementia. All right, the polls are in. And we had the biggest was cardiac, 40%. Second was cardiac. I'm sorry, second was, sorry. Oh, yep. First was cognitive. Sorry, I mixed the blues up. So more people worried about dementia than anything else. Second was cardiac, and third was metabolic, type 2 diabetes. I figured it was kind of a three-way between those three. Those are the big three. But one of the things that data can tell you, and there wasn't enough time to give a presentation on this, the highest correlated with mortality at age 70, 15-year mortality, was actually kidney health. But we don't even measure our kidney health. Most people don't have cystatin C in their blood test. So if you actually took the 5% of people of 70-year-olds with the best cardiac scores and compared them to the 5% of 70-year-olds with the best kidney scores, the people with the healthiest kidneys had 30% less mortality. So if you want to live long, there needs to be a lot more data analysis and education on kidney health. And I actually asked at least four different nephrologists if they knew of any literature out there on how to be proactive about kidney health. And not one, they couldn't list one paper. And these are the kind of insights, why I asked the original question, what if the health system actually used its data? We have the data out there. We're just not using it. We're not looking at the right diseases, the right predictors. And once we have that, then we can address the root cause of diseases. So the simulator, again, it's a resource we put out there. You can plug in your blood work. You can even modify things to try some what-if scenarios. Like there's sliders in there. You can drop the weight 10 pounds and see how it affects your risk scores. And again, these are all free resources we put out on our website, voloridgehealth.com. So I gave an example from the biomarker reference guide. Again, there's the printout version in your bags. I gave LDL cholesterol. I wanted to compare that to HDL cholesterol. And again, much stronger predictor of just about every disease. In fact, LDL cholesterol is not only a weak predictor, but our genetics data show that it's mostly genetic. Whereas HDL, you can actually improve through exercise, your kidney function, you can improve through weight loss, and those are much bigger predictors. So if there are three takeaways, if there are only three things you remember from this presentation, one, the health system needs to use its data. It needs to be data-driven. Two, I'd say the top two predictors of just about everything are cystatin C and A1C. So measure those two markers in the blood test. And number three, I think a good takeaway is that HDL is much better to look at than LDL. LDL is it's just a weak predictor. There's not much you can do to influence it. And again, this is not just my own anecdote. This is looking at research and tons of data, like people losing weight and not the LDL doesn't improve, but the HDL does improve. So HDL over LDL for just about everything. This is just a sample of what the report we're working on. I actually have some printouts with me of a beta version of our report, which will be available in our simulator. But how a system like this can help a medical practice? One, it saves time. If you use data, you don't have to sift through every single biomarker and hypothesize about it. A good report, a data-driven report, would just put the highest most actionable biomarkers at the top. Second, it promotes proactive care. A person can track their progress over time. It educates the patient. It empowers the patient because they actually can understand what's going on. Like, why am I being told this marker is too high? Well, because the association is such and such for this disease. And it enables personalization. So with that, I'd like to thank you for your attention, and I hope you'll learn something from this presentation. I want to especially thank the Vogel Foundation for contributing to the research and Voloridge Health, but also the UK Biobank. It might be the world's best data set, and they made this available for researchers. And at this point, there are at least hundreds, if not thousands, of papers being done on seeing a big population followed. So really, big shout out to the UK Biobank. And with that, I'm happy to answer any questions.
All right, Dave, I'll prime the pump as your partner here. Are there any other, you mentioned a few of the most notable biomarkers that were surprising. Are there any others that you think are riveting in terms of surprises to the crowd here?
Yeah, so on the surprise biomarkers, one thing I neglected to mention, Lp(a) is a very, very, very weak predictor. I think it's overhyped these days. A lot of people voted on that one. It's like the new really, really bad cholesterol. It's sort of hyped as. And if you look in the reference guide, you see it has almost no association with any disease. So that only if you had an extremely high Lp(a) do you have a 20 to 30% potentially increase in cardiac event. Let's see, other interesting biomarkers. We did actually, there are interesting ones. We looked at some amino acids too. We saw which ones, again, the UK Biobank didn't have all amino acids, but we saw like high glycine correspond with good outcomes. We saw glutamine. Again, there's some studies showing how glutamine can help with insulin resistance, and that's sort of supported by the data that the higher the glutamine levels, it's a very strong predictor of a lower prevalence of type 2 diabetes. Let's see what else was surprising. Nothing too surprising on the liver. You got GGT, ALT, AST, so nothing too surprising there. Grip strength beat out all the blood work as a predictor of dementia. But that's only with the current state of technology. We analyzed next level technology where you can measure proteins in people, and we're working on making those tests more available. And if you can measure proteins, then the blood work can be much more predictive of dementia. Yeah, so we got more questions? Okay, great.
Hi. Thanks for all of this data. This is it's always humbling to find that everything you know is wrong. But this is great because it makes you think, it makes you, expand your consciousness. So your initial data set, has that been replicated again and again in other populations?
Mm-hmm. Yeah, so right now we're in the process of validating on other data sets, which is it's a really good point. So we have validated that our models work on US data.
Okay, that was.
And we've seen that the patterns are very, very similar. but we're in the process of doing a little more thorough validation just to see if scores, influences change a little bit here and there. But for the most part, the models hold out.
And all of this is available to us on your website to use.
Yes, it's all available on the website, and there's no charge. Yeah.
Thank you for this presentation. Do you have any data sets that apply to children? Because all these values are different in children and adults. And are there any data set that look at mental health, not in terms of cognitive decline, but more about depression, anxiety, stress?
Mm-hmm. So unfortunately, on the first, no, we don't have any data sets we've analyzed on children. And I think the reason why is there's just not a lot of children getting their blood work taken. Obviously there are other markers we could use for children, so it's feasible, but our focus has mainly been on diseases of aging. And then on the second question, yes, there are actually a lot of survey questions in the UK Biobank where you can link depression, happiness rating, job satisfaction, a lot of psychology variables you can actually treat as biomarkers and do the same kind of relationships with diseases. And you sort of see in that case that it's a lot of the literature is correct on a lot of that. Like the happier you are, the lower the prevalence of disease. And so there is a lot of support for the psychological variables. Okay, yeah, over here.
Hi, you mentioned that cystatin C is the most predictive biomarker of coronary events. Is there something unique about cystatin C that's predictive, or do other renal function markers predict as well as cystatin C, like creatinine or BUN or things like that?
Right. So cystatin C was the most predictive. We looked at others. Creatinine is actually a very, very poor predictor, and it's a very noisy variable because people with more muscle mass also have more creatinine. So it can be high for two reasons: either you're unhealthy or you have more, or you're very healthy. Now, the only reason we kept it as a top predictor is because low creatinine is actually an indicator of a lot of disease. Very low creatinine. So that one, unfortunately, is very poor. It can be replaced completely with cystatin C, which is much less noisy. So some of the other ones rank up there. So like you'll see, if I were to list the top 10, you'd see uric acid, you'd see urea. So those are also important predictors. All right.
Hi. Is there any work towards getting this into the EMR so that it can be available to us providers kind of at the time of a visit?
Absolutely. That's what we're working on. We're basically working on making this available, trying to sync our platform with the EMRs, and that way it'll be very easy to make it available to practitioners. Yeah.
Thanks for the presentation. I wonder whether your data has been adjusted for menopausal women because they have a different cutoff levels for the lipid profile. A second quick question is about is there any threshold for low triglycerides about bad outcomes?
Okay, yeah, those are both good questions. So since we happen to capture the ages 40 to 70, we have, oh, yeah. Oh, okay, so the question one, is there data on postmenopausal women? And I'll answer that one first. And because we have ages 40 to 70, you sort of have the whole gamut from pre-menopause to menopause to post-menopause. And you can actually see, like, if you compare men to women on triglycerides at age 40, men have much higher triglycerides on average, but the women, they catch up over those 30 years. So you definitely can see how biomarkers change in women, even though we haven't looked at the exact, like there's no indicator in the data set for menopause, because we know the approximate age range, we can see the trend. And the second question, oh yeah, and triglycerides, is there triglycerides that's too low? Yes. too low triglycerides can also predict dementia. But generally triglycerides is this curve where lower is better, lower is better, lower is better. And then at the very, very extreme low, you do have some risks. Same with even white blood cell count. If I got really, really granular, like you can see, if I got to the lowest 0.1%, there's some serious things going on with people who are out of their reference range. So the medical reference range shouldn't be ignored for that reason, because extreme outliers cannot be captured in our mass data analysis. Oh yeah.
Hello. We're curious about, could you walk us through the process of how you got to these predictive models and like the research done behind it? That's question one. And two, we're quite amazed in this table about how LP(a) came out to be a really poor prognostic or predictive biomarker. Would there be any difference if you have the data on increasing the cutoff levels for the high ranges? Would that change on the predictiveness or usefulness of the marker?
Yeah, so there are a few questions in there. The first is about the research process. I mean, there's a lot to talk about, but I'd say one of the key things we did was we normalized for age and gender, which is actually, it's a tough thing mathematically to do correctly, because conventional statistics, you use a linear graph to normalize. So people say controlled for age. But if you use a line to fit something that's an actual curve, it doesn't normalize correctly. So if I were to correlate LDL to heart disease, because LDL increases with age, it'll look like there's a bigger correlation than what I'm showing, which is a risk multiplier. So that's just that just scratches the surface, but I could go for an hour on the whole research process. Sorry, the second was.
Yeah, we're just thank you. The second question is just we're surprised in today's table about how LP(a) came out to be such a poor predictive biomarker. Yeah.
Yeah. So we were surprised too, and when we find a controversial result like that, we always assume we might be wrong. Maybe we made a mistake, and we look at other research papers. And when we looked at other research papers, they actually had the same effect size as we did. So like there was a research paper on the UK biobank that was published in a top journal. It showed a 1.07 risk increase for every 50 points of LP(a). Now so the people all the way at the extreme have a 30% increase, just like what we found. But it seems so big because the p-value is off the chart. When you have a big data set, you can have a small effect, but very, very high statistical significance. So our finding actually didn't disagree with any research based on that was data-driven. Oh, yeah.
When we're talking about LDL, are you including the particle size and particle number? Is that thrown out with the LDL?
Yeah, so good question about particle size. We actually figured out of all the ratios out there with cholesterol, almost all of them are useless except LDL divided by ApoB, which we believe is some representation of particle size. And so we had that as a biomarker in our reference guide. We call it the LAR, the LDL to ApoB ratio. It's actually one of the top 10 on almost every disease, and higher is better. You actually want, which represents bigger particle size, we think. Again, we're not biologists, but that ratio seems to be even more predictive than when particle size itself is measured in some of these metabolomics tests. Oh, yeah.
Thank you so much for sharing this information with us. It's an amazing resource. I have a question about other markers. So I'm seeing a great collection of blood markers here. I'm curious if your company is going to be looking at other markers like insulin or adrenal markers or thyroid markers. There's DHEA, there's cortisol. There's so many more labs that functional medicine practitioners often run, which could be relevant. And then expanding on that, functional medicine doctors, we often like to order other non-serum tests. We do stool testing, we do urine testing, salivary testing. So I'm curious if there's a vision to start looking at data like this with some markers outside of blood work. Just curious.
Absolutely. We want to expand to pretty much anything we can measure. We actually do have a set of physical markers. So we do have blood pressure. We have resting heart rate. So anything we have data on large amounts, we actually include in the, that's why we call it the biomarker reference guide rather than just the blood work reference guide. So it really expands to everything. We even added some lifestyle variables in there, like how many servings of meat per week, and you could see how the association with different disease. Unfortunately, we did not have insulin in our data set, which is something we were really working hard toward, because I've also familiarized myself with thousands of research papers, and I'm aware that insulin is probably the underlying preventive biomarker for type 2 diabetes. And there are actually a few people we've seen anecdotally who've sort of fooled the model. We saw they had high insulin, but they actually got lower scores because we didn't have insulin in the model, because their A1C was good and their BMI was good. So there are some important markers that we haven't been able to get yet, but it is in the vision to get every important marker that we could find. Thanks. All right, well, we are about out of time. I hope I got all the questions. Well, thank you all very much.